Thank you to Asma for inviting me to talk to you about the sonographer's role within the MDT. I'm last on the list today, which means that you've probably heard a great deal of what I'm going to talk about, but this is really feet on the ground and the basic side of things before they get to the upper echelons of professors and fetal medicine specialists. When I was putting this talk together, I saw this very old quote. This chap died about 150 years ago, but it's quite an astute observation that actually we're really very interesting before we're born. And I think with multiple pregnancy, that's even more interesting. Another interesting fact is that with the techniques of assisted conception getting better and better, you can see here the number of 45 and over year olds actually in units across the UK, or rather England and Wales, has reached 100 now, and it's quite staggering how many more women are being successful in having multiple pregnancies, certainly twins. We know from NICE guidelines that if a woman is having a multiple pregnancy, she should be offered specialist care. She's going to be a high-risk pregnancy, she's going to need more support, she's going to need more visits to the hospital, she's going to need an awful lot more intensive monitoring. And at St George's Hospital, we've run one of these specialist clinics for a number of years now. Now you've met the doctors, you've met the midwives, and now it's my turn. Sandra on the last talk alluded to the fact that women that come in for their first scan, they actually have no idea they're carrying a multiple pregnancy, and for that matter, nor does the sonographer. And giving that news to the parents is actually quite devastating sometimes. It's not necessarily a completely joyous occasion, it's extremely shocking. And the first reaction tends to be shock. How are they going to cope financially, emotionally, and physically? And that leads on to needing the enhanced team, and these are just a few of them. We need access to these other specialists to help with the care of this woman. Now at St George's, it means that this woman will have less visits to the hospital. And we can also offer emotional support to the parents as sonographers, because behind the closed door of the scan room, it's very emotive actually watching your babies on a screen live in front of you. And so we can offer more support there. The other important factor is that you shouldn't really have just one person that is your sonographer that specialises in this field. They need the support for each other, and you need that honed in operator accuracy, so you can rely on the findings as the clinicians for the results of the scan. Now in the instances where the sonographer finds a problem, then we've got easy consultant opinion because we run these specialist clinics. The team is on site at the same time. And because of that, we have really good communication amongst the team. So when the parents have come in and you've broken the news that this is a multiple pregnancy, our job is to look at the chorionicity, the amnionicity, and the number of fetuses. And that will determine her care pathway for the rest of that pregnancy. So we have to get it right. And if there's any sign that the jury's out on whether you can actually see a very thin membrane or not on a monochorionic pair, that's when that sonographer will call in a senior sonographer. Now, we have a twins team of sonographers, and those twins team girls actually look after the ladies from 16 to 24 weeks for TTTS observation or screening, and then they look after DCs and monos for their late second and third trimester growth scans. The rest of the ultrasound team within the unit are quite capable of looking for chorionicity at the first trimester, and they perform the anomaly scans as well. We also know that the RCOG guidelines are being updated currently. They haven't been published yet, but this will probably mean that the observation of monochorionic twins will change as it currently is and be much more intensive monitoring. So this is a simplistic way of looking at what Sandra's just actually presented. But if you're a dichorionic set of twins, you get a minimum of 8 visits, and at 6 of those you'll have a scan. If you're carrying monochorionic twins, there are a minimum of 9 visits, and all of those visits constitute a scan. So it's up 50%. And obviously with triplets, very intensive monitoring. And the trichorionic, triamniotic triplets are very similar to the dichorionic twins. Now, the current protocols for scanning in our FMU, we adhere to the NICE and RCOG care pathway for chorionicity. We have the specialist team for the TTDS and the growth scans. We look for transvaginal scan of the cervical length at the anomaly scan. We perform uterine artery Dopplers, and we start looking for growth discordance, displayed as a percentage, from 20 weeks. If they're a monochorionic set, from 24 weeks, we look at the PSV of the MCA that's angle corrected. So that's what we do in a sort of nutshell, but I've only been speaking for about 5 minutes, so I thought I would actually break that down into what we actually do, why we do it when we do it, and what we're looking for at each stage of the trimesters. So first trimester scan, we've identified a multiple pregnancy, we've got triplets up here, we've determined the chorionicity, you've got a lovely lambda sign here, and I know you've heard a lot about chorionicity today. Pregnancy dating, Baski talked this morning about dating, about what we should do, whether we take the smaller, the bigger, we average. The jury's out at the moment, but the protocols actually state that we date on the largest twin. Which IVF date are we going to use? Is that oocyte retrieval? Is it reintroduction? Or is it going to be simply the date that the clinic have given the lady for her EDD? Are the parents aware that major abnormality is more common with twinning? This is an anencephalic baby here. We also have to screen for Downs, Pataus and Edwards syndromes. And this is a new call that I did the other week. And we also start at that point in time the nomenclature of the babies. So we can label A, B, 1, 2. We can colour code them. But whichever we're labelling, we look at the gestation sac that is closest to the internal os. And we need to impart to the parents that actually just because we label twin 1 doesn't mean that twin 1 will come out first. So we've talked about chorionicity, and this is a very clear demonstration of the placental tissue coming in the lambda sign into the thickened membrane, and this is the T sign, a very thin membrane here. There's no point looking at the other end of the membrane if you're going to look at that and it's not going in towards the placental tissue. You're not going to get the information you need. So we know dizygotic twins will always be dichorionic and diamniotic. If you're monozygotic, it depends when the egg splits. But essentially, as sonographers, we are looking at the placental masses, the T or the lambda sign, and the thickness of the membrane. Now, the problem as a sonographer is when you actually do the chorionicity and say to the parents, oh, well, looks like you've got identical twins, then the odds are on that you're right. If you actually say they're non-identical because you've got the lambda sign, you might be wrong. Now, the reason behind that is that out of all twins, about 30% are monochorionic, and 30% of those monochorionic twins will divide early to give you a dichorionic, diamniotic pregnancy, and you can't tell the difference on ultrasound. You have maybe a dizygotic set of twins where the placentas have merged, so they look like one placental mass. You have to look at the lambda sign, look at the thickness of the membrane, and don't be confused just because it's a single placental mass. All monochorionic, monoamniotic are monos, and all monochorionic, rather conjoined twins are monochorionic. So we've got so far down this line of the scan. We've now got to offer her screening. Does she know that it's an increased risk because she has 2 babies? And we need to make sure that chorionicity is right because it changes how we actually screen that pregnancy. As sonographers, we're always on the lookout for different things. And one of the things that we often see is a discordance between the nuchal translucencies and monochorionic pregnancies. Is it of any actual importance? Well, the trend used to be that, yes, it is, because it could be a precursor to TTTS. But depending on the literature you read, even if you have a discordance of 20%, it's not actually going to change her management because you will still be scanning for twin-to-twin transfusion syndrome from 16 weeks every 2 weeks. So if we look at the screening, if you have a dichorionic pregnancy, you can give an individual risk for each of those babies. If you have a monochorionic pregnancy, they're genetically the same. You can't. You give a result for the whole pregnancy. But what are you going to do when you've got a pregnancy that's a twin pregnancy, but one baby has died? Or indeed, the other gestation sac is empty. It's difficult again for the sonographer because that woman comes in, you say, oh, you've got a twin pregnancy, sorry, one baby's died, and because that baby's died, I can't screen you to the full extent I would have been able to if they were dichorionic and they were a separate couple of babies. So if there is fetal demise in one of the twins, we cannot offer combined screening. You have to use maternal age and nuchal translucency alone. If the other gestation sac is empty and there are no fetal parts, you can use the combined screening because there is unlikely to be contamination of the blood. With triplets, again with monochorionic triplets, it's a risk per pregnancy, and you can give a risk for each baby with the trichorionic ones. And then non-invasive prenatal testing, as Aris alluded to, the new kid on the block. The RCOG scientific paper suggests that with MC twins, there's more free fetal DNA. It could be a more sensitive test, but dichorionics are not quite so straightforward. We also have to look for the rarities that are out there. So we're looking for abnormalities, we're looking for chorionicity, we're looking for multiplicity. There's a huge long list of things that we're on the lookout for, but obviously the rarities too. I've only ever seen one of these in my career, and it's 1 in 35,000. Twin reverse arterial perfusion, we've got conjoined twins, which are very, very rare. And monochorionic monoamniotic. If we see one of those at first trimester scan, we get another sonographer in to actually confirm those findings, and if we are unsure, we will send to fetal medicine, or if we think there really isn't an intertwin membrane, then we will refer to fetal medicine for further care as well. So that's the first trimester. Now, some women unfortunately book a bit late, which means that the further into the pregnancy you go, the less reliable chorionicity is. So we're still going to look for placental masses, intertwin membrane, and the thickness of that membrane, and whether the sexes are concordant or not. About a year ago, the Fetal Anomaly Screening Programme had a biochemist meeting about quad testing, and that of the 1st of April this year has been introduced for all twin pregnancies. And as you can see from here, the actual quad test is not bad for monochorionic twins, monozygotic twins, but it's not so easy with the dizygotic pregnancies, and parents need to be aware of what these results can give. But it's still better than maternal age alone. So in the second trimester, to wrap this little part up here, for screening for 21, we look at the quad test. It's not possible for triplets. We screen for twin-to-twin transfusion syndrome every 2 weeks, from 16 weeks to 24 weeks. All our sonographers are able to perform the routine anomaly scan. We need to make sure parents know that there may be an increased chance of there being a fetal abnormality. And we actually allow 60 minutes for our anomaly scans. Again, we label those babies to make sure we get it right, and we start looking for size discordance at 20 weeks. We look at the cervical length, and we do that transvaginally. We look at the uterine artery Dopplers, and we start to measure the PSV of the MCA, and we angle correct. This is a bit spooky, really, because of the slide we had a little bit earlier. But this is purely from the sonographer's point of view. So we know that with monochorionic twins, twin-to-twin transfusion syndrome is about 10% of those twins, and selective growth restriction is about 10% as well, and TAPS is very, very rare. So if we just look at the twin-to-twin transfusion, what are we looking at as the sonographers? What are we screening for? The most important thing is the change in the Lycol volumes between the two babies. We need to make sure there isn't polyhydramnios associated with oligohydramnios. We also need to look at the fetal bladders, because that will change as well. There might be fetal size discordance. It's not necessarily a huge, obvious thing that you might see. It really is the first 2 points on that list. If you're a brave sonographer and you suspect that there may be TTTS on the horizon, you can try looking at the Dopplers. The umbilical artery in the donor twin will be abnormal. Can be staged for severity. That's not our remit. So twin anemia polycythemia sequence, very rare. I had never heard of it until about a year ago. And it's really looking at this measurement of the PSV of the mid-cerebral artery. And we're looking for anemia. There won't be the Lycor discordance between the two babies. And I'll show you some examples of it in a moment. Selective fetal growth restriction, likely due to disproportionate sizes of the shared placenta. So what's the difference between TTTS and selective fetal growth restriction? From our point of view, as this visiting on one of her routine screening scans, The bladders will be a similar size, and you won't get the polyhydramnios. You might get a little bit of oligohydramnios, just like you would with a singleton experienced IUGR. So with TTTS, we are looking for the T sign to ensure this is a monochorionic pregnancy. Are the genders concordant? Is there a like or discrepancy? As a junior sonographer, I didn't really understand what folding or tenting membranes were. If you got a piece of material and stuck a pole up in between, you get that folded membrane, and that's exactly what it looks like. And you can see down here the tenting of the membrane there. The bladder filling discrepancy, potentially fetal size discordance, and abnormal Dopplers. And this is what it looks like. So you've got a large bladder, polyhydramnios. You can see a significant growth discordance here, oligohydramnios here, and not so big a discordance here, but you've definitely got the polyhydramnios associated with the oligohydramnios. And this is the absent end diastolic flow in the donor umbilical artery. So TAPS, this was a case from January in our unit earlier this year. And you can see a nice little red foot and a white arm there. And this is what we're looking for. Now, with the physics of ultrasound, it is important to angle correct your measurement here. You're not simply taking a resistance value, you're actually looking at peak systolic velocity. And you can see here on this baby, it's 40, and on this one, it's 22. And you can see the colour coding difference between these two, because in our unit, we actually colour code. It's much easier than labelling up a baby every time you want to archive an image. We use Viewpoint in our system, and this is what it looks like when you actually look at the recipient twin here, and this is the anemic baby here who is the donor. So that's what we're looking for on our readings. And obviously we would refer straight away if we saw anything remotely like that. Fetal growth discordance, I think this has been mentioned already. We look at the larger twin, take away from the smaller twin over the larger twin times 100. It's displayed as a percentage. And what are we likely to see on ultrasound in the smaller twin? Well, it's very similar to a singleton. You'll get oligohydramnios, Doppler changes with reduction of the MCA PI and increase in the umbilical PI, and there won't be any bladder filling discordance. So if this growth discordance is equal to or more than 25%, we would refer because the risks of adverse outcome increase. So we're nearly there. We've got it to the third trimester. Our growth scans take about 30 minutes, and again, we label and make sure we've got the same twin each time we go through the pregnancy. Warn the parents about the birth order, looking for the size discordance, and we look at the fetal Dopplers on both babies, whether mono or di. So what are the advantages of a multidisciplinary team? Well, it's essentially promoting safety for both the mother and her babies. Fetal anomaly screening program gives us guidelines and standards for best practice as sonographers. The same sonographers to give consistent intra-rater reliability for measurements so that clinicians can depend on them. And the same sonographers for patient contact. It creates a bond, it creates a relationship. The same sonographers for each other to confirm to confirm findings and support each other, and also that experience and knowledge of knowing their own limitations. So the aim is really to optimize best possible outcome for parents and babies alike. Thank you very much.